Уэйна Морриса. Он бывал в России, и несмотря на все вызовы сегодняшнего дня, мы сохраняем контакт и с Европейским обществом анестезиологии и интенсивной терапии, и с Всемирной Федерацией. И Уэйн сейчас в своей видеолекции расскажет нам о глобальных приоритетах для анестезиолога-реаниматолога в постковидную эру. Лекция в видеозаписи, а после этого уже у нас начнется официальная процедура открытия. Пожалуйста, уважаемые коллеги, поставьте лекцию Уэйна.
Thank you very much for inviting me to speak at this very important meeting. I'm sorry I cannot be with you in person. I will start my presentation. This talk is entitled Global Priorities for Anesthesiology in the Post-COVID Era. Firstly, greetings from the World Federation of Societies of Anesthesiologists, the WFSA. Our mission is to unite and empower anesthesiologists around the world to improve patient care. The WFSA was founded in 1955, so we are almost 70 years old. We currently have 133 member societies, and we represent anesthesiologists in 150 countries around the world. Very importantly, we have an official liaison role with the World Health Organization, and this means that we can speak on behalf of anesthesiologists at official WHO meetings. While preparing this talk, I thought of the story Rip Van Winkle, an American story written by Washington Irving. It's about a man who drinks too much alcohol and then falls asleep by a tree. He wakes up 20 years later and the world has changed. Imagine if you fell asleep at the beginning of 2020 and woke up only 2 years later. Just consider how much the world has changed during the last couple of years. And it's amazing to think that we have seen these sorts of scenes during the last 2 years. This is a photo taken in India. But hopefully we have turned the corner and we can now start talking about the post-COVID era. During this talk, I want to first outline the concept of universal health coverage. I'm going to look at the impact of the COVID-19 pandemic on our specialty and also healthcare in general. And then I'm going to outline two broad post-pandemic priorities for our specialty. Firstly, continuing to advocate for our patients, and secondly, continuing to develop a well-trained, resilient workforce. And then I'm going to ask the question at the end, whether we can use the COVID-19 pandemic as a way of working towards more equitable health systems. Firstly, the concept of universal health coverage, or UHC. This is the idea that all people have access to the health services they need without the risk of financial hardship. And this is a key concept in global health. It's based on the WHO Constitution of 1948, which declares health to be a fundamental human right. However, we've still got a long way to go. In 2015, the Lancet Commission on Global Surgery found that 5 billion people out of 7 billion people worldwide do not have access to safe anesthesia and surgical care when needed. The Lancet Commission also said that surgery needs to be considered an integral part of universal health coverage. It is an indivisible, indispensable part of healthcare. So when we are advocating at the WHO meetings or in other fora, we say you can't have universal health coverage without safe surgery. And you definitely can't have safe surgery without safe anesthesia. After 2015, the Lancet Commission, and also a publication by the World Bank, it appeared that we were making some progress. People were starting to understand that anesthesia and surgical care were a really important part of global health. But in 2020, the pandemic happened, and everything ground to a halt. This is a graphic taken from the United Nations website. And at the top, it states that COVID-19 is threatening decades of progress in global health. The UN estimates that 500 million people worldwide have been infected, and 15 million people have died during the last 2.5 years as a result of the virus. The pandemic has disrupted essential health services in almost all countries worldwide. It's led to a drop in global life expectancy. Worryingly, there is now decreased immunisation coverage for non-COVID infectious diseases. There's evidence to show a large increase in the prevalence of anxiety and depression. And the number of deaths from other non-COVID infectious diseases like tuberculosis and malaria have increased. What I want to stress is what's written in the top right-hand corner, that the COVID-19 pandemic has halted progress on universal health coverage. Dr. Victor Singh from the University of Colorado produced this graphic, which shows the 4 waves of the COVID-19 pandemic. The first wave relates to immediate mortality and morbidity of COVID-19. You can see that there is a long tail to this first wave, the post-ICU recovery phase. There is a second wave where there is a large impact of resource restriction on urgent non-COVID conditions. So resourcing for COVID takes resources away from resourcing for urgent non-COVID conditions, including surgical care. The third wave is where there is interruption of care for other non-COVID chronic conditions. But there's also a fourth wave, and this has continued to increase over time. And this is the wave that represents psychic trauma, mental illness, economic injury, and burnout. And we still do not understand the full impact of this pandemic. We've all seen in our own hospitals delays to surgical care, or perhaps cancellations of surgical care. And in most institutions around the world, in most countries, there is now a large backlog of surgical cases. A group called the COVID Surge Consortium did some early modelling in 2020. This group just looked at 12 weeks of COVID disruption, and they estimated that worldwide 24 million operations were either postponed or cancelled as a result of 12 weeks of COVID disruption. They also modelled how long it would take to clear the backlog of postponed or cancelled cases. And they estimated that it would take 45 weeks, even if surgical capacity was increased by 20%. This group continues to do some modelling and will be soon publishing latest modelling related to the impact of the pandemic over the last 2 years. But I spoke to one of the group's lead researchers recently, and in her opinion, we will not see the backlog cleared in the foreseeable future. For the WFSA, the COVID-19 pandemic has had a very large effect on our programs. There was cessation or suspension of the fellowship programs. These are where young anesthesiologists get the opportunity to do subspecialty training in another institution in their region. We also weren't able to have any face-to-face meetings, so there were no scholarships for young anesthesiologists to attend regional conferences. Of course, the World Congress of Anesthesiologists, which was scheduled for Prague in 2020, had to be postponed until 2021 and was then held as a virtual meeting. We also had to stop short subspecialty courses, such as Safe Obstetrics, Safe Pediatrics, and the Essential Pain Management Program. Looking at the fellowship program, this graph shows that we were offering around 50 fellowships per year prior to the pandemic. This dropped to less than 10 during the last couple of years, but we are hoping to restart fellowships during the next 1 to 2 years, and are hoping that we will be able to offer around 30 positions next year. The other big issue is wellbeing. This picture is taken from the front page of a report published by the British Medical Association entitled "The Impact of the Pandemic on the Medical Profession." The report, which was just released recently, outlined that there was a threat to physical health, but also a very significant negative impact on mental health and emotional well-being. Just thinking about the threat to physical health, the WHO in 2021 estimated that over 115,000 health workers died during the first 18 months of the pandemic as a result of COVID-19 infection. And thinking about the mental toll, this is a quote from a hospital doctor in Wales, which is contained in the BMA report. Honestly, it was horrific. The patients were incredibly sick. There was a general feeling of being helpless. You do everything you could, and they'd just suddenly die, and there was nothing you could do. So when you read a quote like this, you wonder what the psychological effects of this experience will be on this particular doctor. And I'm sure a number of you in the audience have had similar terrible experiences. It's very important to remember the effects on other areas of healthcare. As I mentioned before, one area of concern is that there has been a reduction in immunizations for non-COVID illnesses. And one that is of particular concern to the World Health Organization is a reduction in measles immunization. The WHO is concerned that we will see increased numbers of measles outbreaks during the next few years. Getting back to surgery, there has been suspension of cancer detection and screening. And only time will tell what full impact this will have on overall provision of treatment for cancer and other surgical disease. So what are our priorities? I'm just going to look at two broad areas. The first is advocating for our patients, and the second is building a resilient workforce. So the first priority, advocating for our patients. I'll go back to this slide from the Lancet Commission on Global Surgery. 5 billion out of 7 billion people worldwide do not have access to safe anesthesia and surgical care when needed. This has likely to have got worse during the last couple of years. And in December of this year, the world's population is expected to pass 8 billion people. So we need to keep on advocating on behalf of these patients. Surgical disease accounts for a large burden of disease worldwide. Schreim and colleagues in 2015 published a paper which showed that surgical conditions and trauma accounted for over 16 million deaths worldwide per year. This was 4 times as many as the deaths due to HIV/AIDS, tuberculosis, and malaria combined. It's interesting to compare these numbers with deaths from COVID. If we agree with the United Nations figure of 15 million deaths during the last 2 years, then on average, the number of COVID deaths for the last 2 years would fit in between these two figures at around 7.5 million. I said before that we had made some progress towards putting anesthesia and surgical care on the global health agenda before the COVID-19 pandemic started. This is a resolution passed unanimously by member states at the World Health Assembly in 2015, Resolution 68.15. And this resolution called on member states to strengthen emergency and essential surgical care and anesthesia as a component of universal health coverage. So governments have made a promise, and we need to keep on reminding governments of their promise. WFSA will continue to work tirelessly at the World Health Assembly and other important meetings to ensure that we put the spotlight on anesthesia and surgical care, and we will also be arguing for greater resourcing of our specialty. The second priority is developing a well-trained and resilient workforce. In 2015 and 2016, the WFSA conducted a global anesthesia workforce survey. And one of the findings of that survey was that there were huge disparities in the anesthesia workforce worldwide. And the scale on the top shows the density of anesthesiologists per 100,000 population. The red colour represents less than 1 anesthesiologist per 100,000 population. The yellow, 3 to 6. And the dark green represents over 20 anesthesiologists per 100,000 population. You can see from this map that there are large areas of the world where there are very low numbers of anesthesia providers. So obvious areas are sub-Saharan Africa. Many countries there, or most countries there, are coloured in red, but there are also areas of South Asia and also Southeast Asia. So the WFSA has been contributing in many ways to help develop the workforce. It's critical that we support the training of leaders and teachers, because it is these people that will be setting the priorities in their own countries and leading workforce development. It's very important that member societies and anesthesiologists as individuals are involved in workforce planning and setting goals that are locally appropriate. WFSA has been running fellowship programs, scholarships, and also short courses, and these all help to reduce professional isolation, to build professional networks, and to develop leaders and teachers. We also have many educational resources, including the Anesthesia Tutorial of the Week. But there is scope for us to be developing more resources that can be used by member societies to train the workforce that they require. For me, it's absolutely critical that we have empowered member societies. Empowered member societies are key. These societies need to be engaging with governments, with decision makers, with other healthcare workers. They need to be involved with national planning and setting local priorities. In short, they need to be leading on workforce development. The WFSA is a federation. We are our member societies. It's very important that we are united, and we can achieve so much by working together. I'm just going to end with a couple of slides on the possibility of developing more equitable health systems in the wake of the COVID-19 pandemic. I recently read an editorial in The Lancet entitled, "Will the COVID-19 crisis catalyse universal health reforms?" It's a very interesting article, and it made the point that historically, universal health reform has often been born out of crisis. The article gives many examples, but here are just three of them. In my country, New Zealand, following the Great Depression in the 1930s, the government introduced the Social Security Act in 1938, which had dramatic effects on the provision of healthcare in New Zealand. In the United Kingdom, following World War II, in 1948, the government introduced the National Health Service, which tackled universal health coverage. In Rwanda, after the terrible genocide in 1994, there was also a decision by the government to look at healthcare in general, and they undertook a problem of universal health coverage reforms. The pandemic has brought attention to deep healthcare inequalities, and we've seen many populations affected in disproportionate ways. There is an opportunity for us to learn from the pandemic and to build back better, to develop health systems that not only will manage a pandemic better in the future, but also manage better the other non-COVID healthcare problems that a health system has to deal with. We need health systems to be comprehensive and also resilient. Here are the key points. Essential health services worldwide have been severely disrupted by the pandemic. We were making progress in terms of getting anesthesia and surgical care on the global health agenda, but this has been set back by the pandemic. Progress on universal health coverage has been halted. Anesthesia and surgical care have fallen further behind other areas of healthcare. There are still many patients in the world who do not have access to safe and affordable anesthesia and surgical care. Our main priorities should be advocating for our patients and also developing a strong, safe, resilient workforce. We have an opportunity to develop more comprehensive and resilient health systems. Comprehensive health systems that include anesthesia and surgical care and provide excellent care for non-COVID patients as well as COVID patients. We can achieve so much by working together. I'm already excited about the next World Congress of Anesthesiologists, which will be held in Singapore in March 2024. It will be a hybrid meeting. There will be opportunity to attend face-to-face as well as virtually. I hope to see many of you there. By working together, we can achieve so much, and it is very appropriate that the theme of the 2024 World Congress of Anesthesiologists is Together We Can. Thank you very much, and enjoy the rest of your meeting.